Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, and we have an awesome doc for you today. So Dr. Arinola Dada is a rheumatologist in Bellevue, Washington. She is double board certified in rheumatology and clinical densitometry. She has been teaching as a rheumatologist for the past 18 years. She wears many hats as a mother, teacher, mentor, speaker, and in her past, she was a science researcher and clinical faculty at the University of Washington. She is currently the managing partner of Overlake Arthritis and Osteoporosis Center in Bellevue, which is expanding to create a state-of-the-art rheumatology and an infusion clinic to meet needs of the growing population of patients with autoimmune disease in the greater Seattle area and beyond. Dr. Dada is a fellow of the American College of Rheumatology and active in multiple professional organizations, including the American College of Rheumatology, the Arthritis Foundation, and many others. She's been the recipient of many awards, including Top Doc for multiple years in Arthritis Today, the National Arthritis Foundation, the My Doc Rocks programs, as well as multiple years in the Seattle Med magazine. Dr. Dada, welcome. We're so excited to have you here.
Thank you, Jillian. I am so excited to be here. Thank you for the kind introduction, and thank you for having me on your podcast.
Yes, absolutely.
So I was thinking, it's amazing that you've really dedicated your time and energy to this wonderful podcast. And over the last few months, I've really enjoyed learning a lot from your podcast. I think one of my favorites is that talk by the Ehlers-Danlos syndrome. I think it was a Dr. Bluestein, and she's just doing such exciting work for Ehlers-Danlos syndrome because that's something a lot of my patients are struggling with too. So from a rheumatologic standpoint, though, autoimmune diseases are on the rise, and I think it's exciting for our patients to have the opportunity to kind of just listen and learn and just be empowered so that they can be partners in their own paths to wellness.
Absolutely. Thank you. Oh, I'm so excited you've been enjoying the show. That's terrific.
I have. It's great. I think in my rheumatology, just kind of as an introduction to myself, is that in my practice, I help people with autoimmune diseases and rheumatologic conditions preserve their joint and immune function so that they can live an active life. And so that's kind of my mission. I know that although rheumatologic conditions are not simple or straightforward to manage, the science and medical understanding just continues to advance rapidly. So I think it's one of the most, I know I'm biased, but I think it's one of the most exciting specialties in medicine right now. And I really consider myself lucky to be part of that specialty.
Oh, it's fantastic. Even in the conversations that we've had, you know so much. It's like amazing. There's so many details in rheumatology. And it seems like that specialty is even becoming a little bit more like it used to be rheumatology, and now it's more immunology, right? It's more like about everything in the immune system.
I think so. And I think that's probably triggered more by our understanding of how the disease conditions respond to the different treatments. And I think when we understand how the condition begins, then we can understand and have a little more focused or more targeted treatment. So back in the day when we just had steroids for everything, now we have really more targeted on a molecular level. Okay, this medication works for this condition, and now we understand why. And so it's almost like once we're successful in one realm, you get excited. Oh, wow. Well, then what are the other options here? What if you target another molecule? So I think that's kind of where the rheumatologists have kind of become more excited and interesting immunologists. So yes.
That is amazing. And so talk to us about like what is the same and what is different about all these different conditions? Like where do they overlap and how do they differ?
I think that if we think about the immune system, and I love my analogy, so I'm going to use them. If we think about the immune system as kind of our body as a country and the immune system as a military. And so the immune system is there to protect us from invaders, and those invaders can be foreign or domestic. So if we think about the foreign invaders, so that kind of bacterial and fungi and anything we don't really want in our body, and then the domestic invaders are things like the cancerous cell, right? So if for autoimmune diseases, the problem is that the immune system, which should be protecting us from these invaders, foreign and domestic, have turned their guns and this time are attacking the normal populace, and those are our cells. And so I think one way to refer to our cells is as self-antigens. And so I think if we remember self-antigens as being part of our cells when we're having discussions, then we kind of understand what exactly that means. So if we think about this is a kind of a broad categorization of autoimmune conditions, and then we think about the disorders. So we can have something like lupus, which is one of the things that I treat. And it's the immune system can attack anything from, I like to think about from the scalp to the tippy toes and any organ in between, eyes, liver, kidney, heart, nails, anything can be affected in lupus. Vasculitis, where imagine there are blood vessels everywhere, and vasculitis just means inflammation of the blood vessels. To something like autoimmune thyroiditis, which is just really focused on the thyroid, and just the body develops immune antibodies and the thyroid is under attack. And then finally, something like multiple sclerosis. In this case, the brain is what's under attack.
And so sometimes is it this, when we look at what's under attack, is it a specific group of cells, and that sometimes those cells are co-located like a thyroid or a brain is in a place, versus something like the vessels, which are all over? So the attack can be cells all over, or the cells being targeted can be in a particular location. Is that right?
Yeah, that's exactly right. So just kind of depends on, when the body creates the antibodies. Sometimes it creates antibodies that target a specific antigen, and that antigen is only found in a specific organ. So that's where the antibodies will know where to go, versus targeting an antigen that's all over the place in something like lupus, where you're attacking nuclear material. And as you can imagine, every single cell has nuclear material, so it's endless.
Yeah. Oh, wow. That's a big battle.
Yeah, I know. So I think the way I like to think about the autoimmune disease is that the autoimmune disease originate from kind of the same process that keeps us safe. Mm-hmm. And then developing an autoimmune disease means something has just gone horribly wrong. And the body doesn't really just say, oh, just because you make one mistake, you're doomed. No, it has multiple checkpoints. And so really for us to develop an autoimmune disease, it means that multiple checkpoints have failed. Yeah, so because the body it gives us multiple chances, multiple opportunities to be good. And if we still have some bad players kind of just sneak through the cracks, and that is when we develop an autoimmune disease.
How many different types of cells are there in the immune system? Can you talk about some of these different players?
There are a number of them, and I like to think about them as groups. So if I go back to my favorite military analogy, and no, I was never in the military, but I love the analogy for this situation. So if you think about the T and B cells, I like to think about them as commanders, okay? And they will orchestrate or control their platoons. Within their platoons, they would have things like foot soldiers. Some of these foot soldiers are things like, complements and even cytokines, right? And the B cells also have their own platoon. Sometimes the T and B cells talk to each other. Sometimes the foot soldiers, some things called macrophages, go and get information. And so when these macrophages go get information, they process that information and then they present it to the commanders, the T and B cells. So they're called like antigen presenting cells, where they go, they get the information, they digest the information, and it has to be presented in such a way that the commander can understand it. And so those are antigen presenting cells. So kind of in short, we've talked about T cells, B cells, antigen presenting cells, complements, which when they are depleted, they can set off a war. And cytokines, which I think we always think about cytokines as being pro-inflammatory, but they actually are cytokines that are anti-inflammatory. They're cytokines that bring things down. Because if we think about it, if our body creates a response to a trigger and there is this inferno, well, what's going to stop it? You need cytokines to stop it. Otherwise, the whole body gets consumed. So you have cytokines that kind of promote the inflammation. And then you have cytokines that say, okay, it's enough. Don't set the whole house on fire. The kitchen is a problem. Keep it within the kitchen and let's get rid of it. White flag, the war is over. Let's calm this thing down so that it doesn't damage other normal cells, so that we minimize collateral damage.
And how do you distinguish between kind of the innate and the adaptive immune systems?
I think the way to think about the innate is more like it's a rapid, non-specific response. So to any challenge, so whether it's trauma, infection, if you think about just hitting your hand on something and it gets swollen immediately, your body didn't have to think about that. It just happens almost immediately. It gets, so you have white cells there, you have some cytokines in there. They react immediately to any infection, trauma, or stress. Meanwhile, the adaptive immune system is really slow. That kind of takes days to week. And I think another one of those analogies is the TMB cells. They come in, they survey the environment, and then they go back and say, well, we have this particular trauma, and we look at it as a jigsaw puzzle piece. Let us create another piece that is going to form perfectly with that piece that we have. So we're going to fit the puzzle together. And once we fit the puzzle together, then we will be able to create a more aggressive response.
Excellent. And so are some rheumatological diseases part of the innate immune system, the adaptive immune system? Are they all part of the adaptive? Where do the diseases come in?
Kind of need both to function. So for instance, within the innate system, we could say that, okay, there's an insult, and part of that innate immune system is something like those macrophages that come, and those foot soldiers, they come, they take some information and they take it to the TMB cells and say, hey, this is what's happening. And the TMB cells then come up with a plan to create that second piece of the puzzle that goes back and finishes the job that the innate system began. So you kind of need both. I know it's theoretically, we like to think about them separate, just easier to understand. But I think the way to think about it is an orchestra. And there are many things happening all at the same time. So I think that way we can kind of connect the fact that, yes, the innate immune system is happening, but it is sending signals to the adaptive immune response. And then the adaptive immune response, the thing to remember about it is that the adaptive immune response, it remembers forever and ever and ever. It will remember that I came across this antigen and I have created antibodies. And if that antigen ever comes back, there's going to be a bigger war. And that is how, even vaccines work to some extent, right?
So this is like a big Game of Thrones.
It is, the North remembers. This now remembers. Yes.
So what does a typical rheumatological workup include?
A typical rheumatologic workup, I think, includes, so the patient comes in and you do a physical examination. So the patient comes in, you get a history. And so with the history, I think it's, patients say, oh, you really listen to us. One patient told me yesterday, say, you're one of you that really listen. I said, the job of a rheumatologist is more like a detective. And so I want to tease out. So I always start with, tell me when you were last well. And they're like, oh, I want to start from yesterday. No. I want to know 10 years ago. When did you start having symptoms? Because I'm looking for things. I'm trying to find out, yes, you came in with 2 swollen wrists, but I want to know if you've had back pain as a teenager. I want to know if you had inflammation in your eyes. And you're like, oh, what does that have to do with anything? I want to know if you have skin lesions in your scalp behind your ears. Do you have psoriasis? I want to know if you've ever had problems with your Achilles tendon. I want to know what your bowels are like, And so we want to get a good history. And the fact is that over the years, the immune system has probably been having episodes of starting and stopping and starting and stopping before it became full blown. I like to think about it as the good cells and the bad cells, and they're kind of in a war and trying to figure out, who's going to sit on the throne, right? So because you have regulatory T cells, you have some T cells that are trying to make sure that all these antibodies that are targeting your normal cells, that all these antibodies don't get out of control. So you may have had over the years starts and stops and starts and stops. And I want to know about that because it's going to help me categorize the disease better. And once I can categorize it, then we can talk about the treatment plan. So we start off with the history, and then the next thing is the physical examination. So typically the examination would look at, I would start everything from just evaluating the skin, the nails, the scalp, looking for psoriasis, the joints, looking for swelling. Do you have any nodules? Some autoimmune disease, gout and rheumatoid arthritis can end up with nodules on the skin. Looking at, the joints and say, well, we call it synovitis when you have inflammation in a joint. If the joint is inflamed, then we talk about, can I take a little bit of fluid out to analyze it? Is it something where we've kind of tried and we can't figure it out? And they say, well, maybe we can get one of the orthopedic surgeons to do a biopsy so we can actually figure out what kind of cells are causing the problem. And then, other things are X-rays and MRIs if necessary. Blood tests in autoimmune diseases. Unfortunately, most rheumatologic disorders do not have perfect tests. So, for instance, there's this notorious ANA test, and it doesn't necessarily predict lupus or autoimmune diseases. I'm going to sidetrack for a little bit and say, so when I kind of think about how to think about an autoimmune disease, right? If I think about that, and I think it helps with the ANA idea. So there are multiple theories about how autoimmune diseases occur. One of my favorite, because it kind of resonates with the number of conditions that I treat, is the idea of cell death. So when cells are young, they grow, they die. And when they die, it's supposed to be nicely orchestrated. And it's called apoptosis, or programmed cell death. So if you think about a piece of paper being crumpled and then pieces of it breaking off, and you think about the macrophages, they're kind of like the dumpster guys. They come and they take up all these pieces and take it to a recycling bin, the spleen or the liver. And it is clean, it is well orchestrated, it is civilized, there are no weird particles dancing around, it's done. But in some patients and some people, the cells may die by explosion. And in that case, all the particles just get scattered around, and the macrophages come and the cleaning systems come, but they're just overwhelmed. And so you end up with this nuclear debris lying around. And then the body is like, well, what is this? Because it has never been exposed to. So as far as the body is concerned, as far as the immune system is concerned, it's thinking that this is foreign and it is going to create antibodies against it. And so it can, conditions such as lupus, create anti-nuclear antibodies. So sometimes you do an anti-nuclear antibody test and you find it's positive. But just because you have that antibody does not mean that you will develop lupus, because we talked about the fact that the body has multiple checkpoints. So you could have the nuclear debris and the body could say, you know what, I'm not going to create antibodies against this. I'm going to ignore it. Or the body can say, well, we'll create some antibodies against it, but it's not going to they're not going to be very sticky. They're just going to be a few antibodies. Or we can create antibodies against it. They may stick, but it'll never cause inflammation. We're going to stop it right there. Or it can create, inflammation, and the T cells and B cells that are going to target the nucleus that have been created after the innate response, when they're passing through their checkpoints, there are checkpoints that say, well, what's your target going to be? And it says, I'm going to attack the nucleus. And it says, well, no, we're not going to allow you past this checkpoint. You will go back to training ground. And so those are like self-reactive T cells and B cells. So the body has a way there too of saying, no, we will not allow you to destroy self. So you will go back to training ground. But people with autoimmune disease, they can just create this. And the checkpoints, they fail, they sneak past the checkpoint and they go, and then it becomes a full-blown autoimmune disease. So that's why just having the ANA doesn't mean that you will develop an autoimmune disease, because there's so many checkpoints to protect you. So it's only when all these checkpoints fail that one will now develop a full-blown autoimmune disease. So that's why having an anti-nuclear antibody just means, okay, you had some nuclear debris, your body created an antibody, but we haven't answered all the other questions about, are you really going to fail all the checkpoints? Are those antibodies going to be able to sneak past all the checkpoints? And so that's why just having an ANA test does not lupus mean. It just means, okay, there may be a risk, but your body may be able to clear it. And maybe there's some things that can be done to assist that process too.
So as you were talking, I was thinking about how, your trash analogy is perfect, and I was imagining, how the trash in our neighborhood goes out to the street and everyone has their bins lined up. But then last week we had a windstorm.
Exactly. That is exactly it.
And there was my husband at first tried to put a brick on top of each of the cans, but then finally went out and pulled them in. But many people did not. And so there was trash all over our street.
And the trash guys can only do so much. They're gonna have to leave some behind, for the body to figure out. So for the community to figure out what does he want to do with it, because we're done here.
And yeah, exactly. So what's interesting is that the trash being all over is not necessarily the origin of the problem. It's really, the windstorm has come and we didn't bring in the cans. So there's a way that we are supposed to take out the trash in an orderly fashion, that we need to attend to our environmental milieu. So there's a way that it starts before, just like having a good night of sleep starts with how you wind down before bed. Having a good day where you're awake doesn't start with when you wake up in the morning. It starts really when you go to sleep at night. This is to prepare for the next day. Is that fair to say?
I think that's a perfect analogy, because I think if you kind of even dig a little deeper, is if you think about it, some communities may be better at clearing up their trash even after the storm than others. So for instance, we can think about it's genetic, right? So genetically, some people, so if you think about the communities as different genetic populations, some genetic populations may be like, there was a storm, the trash man came, we still have stuff behind, let's get all the kids out, let's clean up, we're done. And some may be like, maybe this will just degrade and, maybe we'll just wash off, and not even bother to go back and clean up, right? And so that kind of goes with the analogy of just our genetic predisposition. What does our body do when this has happened? Well, what's the next step?
Sometimes we do genetic testing for autoinflammatory disorders. And sometimes I think about as on our podcast, we talk a lot about the environmental milieu in terms of all the pollution. So, it's one of those elements where now it feels like some people may feel like, well, there's trash all over, but there's also pollution all over. So who can keep up? And now I give up, and now now we'll just start littering. We're just going to add to it because there's no way we can catch up. And so I think it seems like there's ways that the body, if we can calm the body down, then we can get our right mind back to start better with the apoptosis as well as the cleanup.
I totally agree. And, I think that if you really can't give up, right? Because the body is working so hard for us anyway. If we think about just the volume of bacteria, fungi that the body on a daily basis is dealing with. So I think whatever we can do on our part, if you think about the amount of bacteria that's even just start from the mouth all the way down into the colon, the fact that we are not overwhelmed with infection is a miracle, right?
Yeah,
So the immune system is, so anything that we can do to kind of help the immune system is powerful, right?
Yes.
Or anything that we can do to minimize just the insult or the triggers, I think will go a long way to kind of minimizing the likelihood that we develop autoimmune diseases. So there are things even in our environment, like even mercury in the bottom dwelling fish. I remember when I was pregnant, thank God it was 10,000 years ago, I'd have to be careful about what kind of fish I ate, right? Because I used to love my tuna, right? And so I had to be careful with, how much of those deep, the bottom dwelling fish I consumed, and now there's studies looking at, even just mercury when we think about environmental factors.
So once we're looking at rheumatological, after we do the history and we look at the physical body and do imaging or do joint drainage, aspiration, and looking at what those cells are, maybe we do some laboratory work. I shouldn't say you as the rheumatologist, maybe you do some labs. Then what are the next steps? What are the different things that you find, and how does that differentiate how you think about treatment?
So even when doing a deep dive into history, part of getting the history is also kind of getting the familial history, right? So you want to know if there's anyone in the family with things like lupus, if, a person's child has psoriasis. If child has psoriasis, you want to ask, well, does your husband have psoriasis? If the patient has had, recurrent bouts of iritis in the past, you want to also, so one of the things that rheumatologists do, almost any condition, is want to make sure there's no infection, right? Because a lot of our treatments suppress the immune system either by targeting certain molecules or just being one of those broad immune suppressants. So we want to make sure that no matter what we do, we cause no harm. So if the body's immune system is busy fighting an infection, we want to make sure that we've ruled those out before we start on that path of, okay, there's an autoimmune disease. Because what we're saying, if you're saying that an autoimmune disease is that a part of your immune system is overzealous and is creating a problem. And the only way to treat that is to suppress the overzealous immune system. So one of the things we want to do is make sure that indeed the immune system is overzealous, right? Otherwise, we end up suppressing the immune system unnecessarily. So you really want to get your facts straight. You want to make sure, you get the family history, find out if there's any predisposition. We do know that genetic predisposition accounts for about 30% of autoimmune diseases. So that's really helpful information. The other things are like environmental factors. We think about toxic chemicals, dietary components, even things like the bacteria in the gut, infections. I think one of the things when you're talking about just getting the history, I think one other anecdote I have is that I remember I've had a number of patients that had like a gastrointestinal illness. So this family particularly, I remember they all went, they had this huge buffet and everybody had a nice time. And they ended up with salmonella food poisoning. And in that family, they had two boys, teenage boys, and they were twins, identical twins. Everybody except one of those identical twins just had the gastrointestinal illness and their body cleared it and they were done. They were sick for a while and done. But this boy had persistent joint inflammation. And so we took the fluid out of the joint, we analyzed it and found he had a lot of inflammatory cells. So he had developed a reactive arthritis. And so, his identical twin didn't develop the arthritis, but he did. So kind of going back to 30% of autoimmune diseases are genetic. And so even identical twins, a lot of autoimmune diseases, they don't necessarily, have the same, it's called the concordance rate, where, what is the likelihood that one identical twin will have an autoimmune disease when the other one does? But that also kind of goes back to kind of one of my other favorite analogies for how people develop autoimmune diseases. This is again a situation where there was an infection. The infection in this case is salmonella, but there are lots of infections that can trigger this. And the idea behind this is something called molecular mimicry, which is just a funky word for the fact that on that bacteria, salmonella, there are a bunch of amino acids or a bunch of genetic information that kind of looks a little bit like some of the genetic information in our joints. And so, like we said, those the innate immune response happens. The antigen presenting cells, those macrophages, they take that information and take it to the T and B cells and say, hey guys, this is the infection we're dealing with. The T and B cells then come back and create the other piece of the puzzle to match that amino acid sequence. And so, boom, they create an inflammatory response. They get rid of salmonella, but they remember. And so they're scouting around, running around, and they find another set of amino acids that look like that salmonella they got rid of the other day. And they're like, well, we're going to attack this because this just looks like that salmonella and we will not be fooled. But this time, this amino acid sequence is actually our joints. So for this boy, that was what was happening. Their salmonella was long gone. His T cells and B cells remembered. They now start creating, because now they're trying to get rid of this amino acid sequence. And so that's kind of this reactive arthritis that's very common in people that have ankylosing spondylitis or are predisposed to it.
So when we talk about in kind of, I have many patients who come in who talk about reading on the internet that their gut can be connected to their immune system. This is a direct link.
That is a direct proven link, and there are numerous bacteria that do this: Salmonella, Shigella, Campylobacter, Yersinia, all kinds of funky bacteria that can do this, molecular mimicry. So yes, so the gut bacteria, and there are other theories. There are even things like leaky gut syndrome, and that have also been shown to predispose people to developing autoimmune diseases, and not just rheumatoid arthritis, not just the arthritis, even things like colitis. Ulcerative colitis and Crohn's disease.
Wow. So that's interesting because now suddenly we're thinking about our gut bacteria. Usually we put that in the arena of the gastroenterologist, but really in some ways it belongs in the territory of rheumatology, immunology.
Definitely. Yeah. The gut is, and so we're looking more seriously at even just sensitivities to food, even like the celiac disease where people have the gluten sensitivity, could that be the final trigger? Because you've been running around with your immune system as it is. A lot of my patients say, what happened? I've been fine for 50 years and now you're telling me I have an autoimmune disease. What happened? Well, so what could happen is that it just finally that stimulus overwhelms the system And then boom, we now develop at the age of 50, after having lived with the same genetic makeup for years, we now have that final trigger. And so sometimes it's gut bacteria.
And certainly sometimes there's the trigger, like a salmonella, like a bad buffet. You should, in the time of COVID, no buffet.
No, nobody's doing any buffets right now, for sure.
And I was just doing a show with my old friend, Anisha Darve, who does Ayurveda and traditional Chinese medicine.
I listened to that.
Oh, you did? Oh, excellent. So she was talking about how periodic, when we talk about that final trigger, when we talk about that burden as we age, the burden gets greater and greater and greater. And so there need to be traditionally, from the traditional medicine perspectives, there were times either seasonally or Anisha was talking about monthly, should be to take down that burden so that we constantly need to be unloading that burden intentionally. It doesn't necessarily happen by just living the life.
I think, especially as we're all getting older and older, I think that, the immune system sometimes just not as effective as it had been in the past. So anything that we can do naturally to try to, minimize the burden that the immune system has to deal with, I think would certainly be welcome.
Yeah. And just before the show, we were talking about Ayurveda and Panchakarma and, some of the other options from the traditional system. So yes, lots of information from everywhere coming in.
Definitely. I think it's an exciting time in autoimmune disease that we can do things to help patients to just improve their quality of life.
Can you talk to us a little bit about the different medications and pharmaceutical treatments that are used for various autoimmune diseases? Like how can we group these to understand them?
It's amazing just how far in the last 20 years, just the study of immunology, and I think probably more even to do with just the technological advances having allowed us to clone certain things. So even cloning pieces of DNA has allowed us to be able to isolate certain molecules. And so that is one of the things that has really kind of, just revolutionized treatments for autoimmune diseases. So we kind of had, the good old non-steroidal anti-inflammatory medications and steroids, right? The non-steroidal anti-inflammatory medications are the ibuprofens and the naproxen, Aleve, those kind of things. And those also work. I think they kind of target more the innate immune system. So they really work by blocking something called COX-2. And so COX-1 and COX-2, and they, have found they eventually blocks prostaglandin, and prostaglandin is really what kind of sets up that whole inflammatory storm. The anti-inflammatory medications are helpful. It just really depends on the severity of the inflammation. I think that's the way to look at it. So if you have a mild amount of inflammation, maybe non-steroidal anti-inflammatory medications will be helpful. And then as you kind of move to the next level of inflammation, steroids are helpful. Steroids, they work differently. They bind to a receptor on the surface of the cell, and most of the activity is within the cell. And so they are able to prevent the production of a lot of the inflammatory cytokines. And they also, even if those cytokines are produced, they can prevent kind of the secretion out of the cell. So they kind of, I guess, not in the way to look at it is the next level up in terms of treatment of conditions. The problem with steroids is just the side effects. If you think about the fact that, well, every single cell has a receptor that the steroids can act on. Meanwhile, you're not trying to treat every single cell. So, that's kind of where the biologics come in, where it's more targeted, right? So I think the first biologics in the autoimmune world was really this TNF, which is called tissue necrosis factor. And fun fact, tissue necrosis factor was found to really it was thought to be responsible for sepsis. And so when in fact, it almost died, they tried to use it in patients who had sepsis, but the necrosis had already begun. So they were using it after the fact, right? Until they used it in patients who had sepsis, and it didn't work. And it became this hot potato that no researcher wanted to touch because they tried it. They thought they understood it. They tried it in, sepsis, mice and, sepsis situations, and it just didn't work. So it was almost abandoned until, thank God, for some diligent immunologists who kind of took it on. And then it eventually became used in conditions such as rheumatoid arthritis. And it has revolutionized just the treatment of autoimmune diseases. So we have about 5 of them, this anti-TNF. And so people say, well, you're just going to suppress my immune system. And I tell them, well, it's really more targeted. So it's more of there's a tissue necrosis factor that is found to cause inflammation, and we are going to directly block it. And by blocking it, we can reduce the likelihood that we're going to target not any other aspect of the immune system. So for instance, people say, oh, well, am I just going to get infections every day? No, you won't get more infections. But if you happen to get an infection, we want your immune system to rise to the occasion. So for that period of time, when they're on antibiotics, just say, well, stop the TNF blocker, let your immune system rise to the occasion, and we can always come back and kind of continue treating the autoimmune disease. But there's so many biologics out there, and I'm sure we can be on this for hours. So Julian is like, God, no. Don't let those immunologists.
Oh, I'll stay here forever. I love this stuff. In returning to the military analogy, this is like one group of rowdy foot soldiers who we have said, oh, behave, you all sit down. And that when we get into a situation like with an acute infection where these rowdy soldiers are the ones who can take care of the problem, we release, we let them all out and they go nuts. And then we say, okay, now back to your lounge, relax.
Exactly.
Can you talk about what does it mean for a medication to be a biologic?
The biologic medications kind of function more on a molecular level rather than the typical ones that kind of just block enzymes. So if you think about the non-steroidal anti-inflammatory medications, they're really blocking enzymes that are in the system rather than blocking something that's that starts a chain reaction. So blocking a TNF molecule is blocking something that starts a chain reaction. So, and when you block that chain reaction, I'm going to go to a different analogy, which is going to show that I've been craving sushi and I haven't gotten sushi in this pandemic, is the conveyor belt. So if you think about it, when we block the TNF molecule, we basically clear the conveyor belt. I tell my patients, we clear the fridge, we even clear the market space. So when you release that, when you stop blocking the TNF molecule, it takes a while to reconstitute all the components that create that inflammatory response. So we're kind of blocking something that starts that chain reaction. Meanwhile, something like the anti-inflammatory medications, they're really just blocking like an end product, right? They're blocking kind of, they're just taking off one of the plates. They're just blocking one of those, one of the end products. So that's why when you can use an anti-inflammatory medication for like a day, and then you're fine for a day, but then once you stop it, the effect is immediate. Meanwhile, something like because you're really blocking kind of the beginning of the whole chain reaction, when you stop the anti-TNF medication, it takes a while to reconstitute all those molecules. So I think it looks more like on a molecular basis. A lot of the biologics, previously we would have said, oh, most of them have to be given intravenous or by shots, but now there are biologics that are given pill form too.
Your clinic now is doing more and more IV infusions. Is that right?
Yeah, so we're actually expanding. With the number of treatment options that are available for the different autoimmune disease, so whether it's rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, lupus, and even gout. A lot of medication options that can only be given intravenously. And so we're expanding to provide that. We're working on creating this center for excellence where we would be treating patients in the clinic setting rather than them having to go to the hospital with all the potential, risks associated with kind of being in the hospital environment, being in a more comfortable environment in the clinic where we're able to provide this service to our community.
The infusions that you'll provide are like rituximab. Are you doing IVIG?
Exactly. No, so we have IVIG, we typically have not given that in our current clinic, but now that we'll be expanding, we will actually be able to provide that as a service for patients because our infusion center is now going to be much more sophisticated where we have what's called a hood to make sure that everything is related to things like IVIG can now be provided for patients in a safer environment. So previously we would have sent IVIG patients to the hospital because we just weren't set up for it. But now with the new infusion center, that's certainly one of the medication treatments we will be offering.
We offer IVIG here. We have it here in our clinic as part of our IV infusion.
That's excellent. Well, if I have patients in Seattle, I'll have them come see you.
Yeah. And then we do, the other nutritional IVs and mitochondrial IVs and mast cell IVs and migraine IVs so people can avoid hospital.
Yeah, that's exactly. I think there's such a need for that.
Yeah.
Just because the hospital costs are really, astronomical. So yes.
I have questions, but are there things you want to talk about?
Yeah. So I think more medications. So I think exciting time, right, in rheumatology. So we talked about the TNF medications, but there are others. There's a medication called Orencia, which, blocks the ability of that macrophage, that foot soldier that brings that information. It blocks the ability of that information to get to the T cell. And so it prevents the T cells from being activated and aggravating rheumatoid arthritis. So that's how something like Orencia, which is abatacept, that's how that works. And, we have other medications. There's something called Actemra and Kevzara. And basically they just block interleukin-6. And although they're used to treat rheumatoid arthritis, I think one thing that it has also made a huge impact on the quality of life of patients is there is a condition, an autoimmune condition called giant cell arteritis or temporal arteritis, which affects pretty much people who are 60 and over. It causes inflammation to the blood vessel in the eye. And so the reason everybody panics when they hear that condition is because there's a risk for blindness. So previously, we would have to put patients on steroids starting at huge doses, 60 to 100 milligrams to preserve vision. And we're looking at perhaps even a year and a half to 2 years of being on steroids. And when we're patients on steroids, high dose for that long, there are definitely going to be side effects. So these medications, yes, they've been approved for rheumatoid arthritis, which is great. They also, especially the Actemra, has been approved to treat this giant cell arteritis. So that has made a huge impact on the quality of life of patients. So I think that I think one of the amazing things that have happened in the last few years is just the ability to treat that condition with a medication that's not going to be almost as bad as the disease, right? Because they're like, okay, tell me about the side effects of steroids. And so tell me about my disease again, So I think that is one of the amazing things. And then I think we talked a little bit about gout and tophi. And there's a medication called Cristexa, which melts the tophi away. It is amazing. The before and after, I had a patient that went through that, and it is amazing. It just melts away the tophi. So, and that is unfortunately is one of those medications that just hasn't gotten to mainstream. So I think one of the things I'm doing now is just kind of talking to my primary care provider friends and saying, hey guys, there's a medication. Your patients don't have to suffer with the tophi. We can melt that away.
And those tophi are those nodules, and they can be
those big, exactly, around the ears, elbows, knees, toes. Sometimes people have to have I have a patient that has different size shoes. He has a 10 for the right foot and a 12 for the other one because he has his lumps on his toes. So his foot can't fit into the right size. So we were able to melt away some of that with the medication.
And that's a new medication then?
It's a newer medication. It's been around for more than 5 years. It's called Cristexa. So previously there was kind of an issue with allergic reactions, but now there's been a workaround so that we're able to treat it without patients having any allergic reactions. So I think that's why it's kind of becoming more, mainstream for most rheumatologists, because obviously you want to protect the patient. So I think now that we have a workaround that, I think that it's probably going to kind of get a bigger audience now. And so, but that is, I think, but probably one of the major revolutionary treatments in the last few years for gout.
So then there's some other medications that we use that are a little bit older, like allopurinol and colchicine.
Yeah, so they all have, I love talking about gout. So stop me when you've had enough. So problem with gout is that the body's just making too much uric acid, right? And it's making more than the kidneys can excrete. And the next thing that patients ask is, does that mean my kidneys are failing? No, the kidneys are fine. It's just that the ability of the kidney to excrete uric acid is genetically determined. So we can have where your kidneys are working fine, as in they can get rid of, waste products and stuff, but that uric acid ability to get rid of that is a special function. And you may or may not have a very good, way of getting rid of it. So it accumulates in the system. And so there are ways that one can address it. We can even start by things like diet, right? So things that are high purine or even high fructose corn syrup, those things can aggravate the uric acid production, and you end up with, attacks of gout. So the allopurinol and Uloric, they in different ways work to just stop your body from making any more uric acid. And so eventually your body clears out the tophi and stuff, and then you don't make any more, and eventually you excrete it at the rate that you can, and then you don't have any more gout. But for people who their system is just overwhelmed, so overwhelmed is when you have those nodules where the allopurinol and Uloric, yes, they will work, but maybe over a period of 10, 20, 30, 40 years, because you've accumulated so much uric acid that it's just going to take a long time. Meanwhile, this medication called Krystexxa actually goes in there and it breaks up the tophi and the uric acid into a form that is very easy to excrete. So that's why within a couple of months, what it would take years would have been excreted. Now, let me be clear, though, that it's not the first line of action, right? So like you said, allopurinol, which is known, trusted medicine, it works. Most of my patients with gout are on allopurinol. If that doesn't work, then we try Uloric, which kind of has the same idea, which is you're making too much, stop making it. You're digging, stop digging, okay? Stop making any more. And then you get rid of what you have. And then in those people who just where the uric acid load is just humongous and they have all this tophi, then these are the patients that we want to consider for Krystexxa.
And then colchicine, that's an old medication as well.
Colchicine is an old medication. I love the story of colchicine. It has it's been around since the 1960s. So colchicine is used for many autoimmune conditions because it just blocks the ability of some of the white blood cells to reach the area of inflammation. So a lot of conditions where there's a lot of inflammation, whether it's gout or something that acts like gout called pseudogout, where your body makes too much calcium deposits, or even something called familial Mediterranean fever. Like the colchicine just blocks that inflammation. So the way to use colchicine in patients with gout is we use it to prevent attacks. So while we're kind of, altering, we're trying to stop uric acid production, we're trying to get rid of uric acid, there's a lot of movement of uric acid back and forth. And anytime uric acid kind of moves either in or out of a cell, it precipitates an attack. Because remember, the body's immune system is looking at these uric acid crystals and is saying, well, who are those? What are those doing there? And it sends white cells there. And the white cells, they engulf the uric acid crystals and they trigger this immune response with cytokines. So it's really not, so having the uric acid crystals alone, that's not the problem. That's not why you're in pain. You're in pain because your body has recognized that there's some foreign things there and we need to get after it. And it sends the white cells and it triggers the immune response and the cytokines and it triggers the inflammation. So one of the way that colchicine works is that it prevents those white cells from migrating to the uric acid. And so, yes, you have your uric acid there, but it's not going to cause that inflammatory storm that makes you feel like somebody smashed your foot with a sledgehammer. That storm.
Nobody likes that storm.
No, nobody likes that.
And so what are the other conditions that colchicine gets used for?
So I talked a little bit about, familial Mediterranean fever, which, they kind of have their fever spikes. And so the story of that is interesting. So people had been using colchicine to treat gout for years and years. And then in 1970, there's actually an article in New England Journal of Medicine that I love to read. And there's this doctor and he had a patient with gout. So then all they had was this colchicine. And so he gave the patient the colchicine, but this patient also had familial Mediterranean fever. And the patient will come to him and say, it's fine for my gout, but my fevers are gone. And so he wrote it up. And that is why till today,
oh wow,
we use colchicine to treat familial Mediterranean fever. So that I love that story.
That is amazing. And it just speaks to, again, how much our medicine continues to evolve and change. And so we're so grateful for doctors like yourself who stay on that cutting edge, who stay aware of the new medications, who stay aware of the new applications, who can think outside the box so that when people come, they don't, the doctor doesn't just say, well, you're getting older, it's probably normal, your memory loss. You do the deep dive, you do the detective work, and you do the learning about everything new that is happening so that we can continue to figure out what's going on with people. It's amazing.
I mean, that's the point, though. I always tell my patients, I'm like, what you don't want to do is, people are reluctant sometimes to try new medication. And it's understandable, But I said, what you don't want to do is transport yourself back to 50 years ago, right? You want to make use of the current technology. And, you're using your cell phone, you're texting. You're not looking for a phone booth, right? Because you could do that, right? You're texting, you're paying your bills online. You're not going to line up in front of the office to see when the cashier will be available so you can pay, right? So we don't want to do those things. So we don't want to transport ourselves. We want to make use of technology. And the important thing is understanding the risks and the benefits of using X medication, and to also and I also encourage just kind of the lifestyle modification, because everything that we can do that, minimize. So I always want to treat with kind of the lowest effective dose of a medicine, right? Because we want to minimize side effects, and all medications have side effects. So we want to minimize that. And so kind of enhancing just, what you can do yourself. And patients ask me that, and I really thrive when I really kind of enjoy the fact that they want to be involved, because I think when they're involved, then we're partners and we can actually get to the results to which we want, which is, having a good quality of life.
Yes, absolutely. So we just have a few minutes left, which is probably not enough for the next bit of topic, but I would love if we could close with something that I know is dear to your heart, which is osteoporosis.
Oh, I love
you like
I love osteoporosis, and maybe because I'm a girl, So osteoporosis is fragile bones. And, if we think about it, especially women, prior to menopause, with the estrogen, we keep building bones, right? And then once we hit menopause, then there is a risk that our bone density declines. And there are certain things that can determine how quickly your bone density declines. Number one is genetics, right? If mom and grandmom all had hip fractures at the age of 60, then, watch out, right? So those are the things that when we talk about doing a deep dive into the history, we want to know, did mom or grandma have hip fractures? If you think about the little old lady on the street who's kind of bent over, where she can't really straighten out, it's most likely that she's had vertebral fractures due to osteoporosis, right? So there are certain things that we can do, even just dietary wise, just being aware that foods that are high in calcium will be helpful, that smoking is not good, again, and that when we drink alcohol, it's in moderation, that walking, the weight-bearing exercises, that effect of the gravity is important. We live in Seattle, so it's the vitamin D, making sure our vitamin D levels, at a certain age, once we hit menopause, important to do a bone density test. And it's really not an invasive test. People are like, bone density, how do you want to check that? It's not a bone biopsy, okay? Yeah. You lie on an
drill
exam
involved.
table. No trauma involved. Lie on an exam table, scan goes over you, and what it does is measures the density in the spine and the hips. And people are like, oh, well, why doesn't it measure everywhere? Well, we don't really care if you break the fingers, your little pinkies. That doesn't really impact your quality of life. What does, if you have vertebral fractures or hip fractures, right? So, and there are medications that can help improve the bone density. And people ask, well, is it going to make it better or just kind of hold still? It actually will increase the bone density. I don't know if you have enough time, but, the medications for bone density just have such a bad reputation. Everybody knows about the avascular necrosis of the jaw, the atypical hip fractures. I get that all the time. Mm-hmm. And I would have to back up and say, and I know that the dentist, best say, one of my sister-in-law is a maxillofacial surgeon. And she asked me one day, and she's like, Arinola, do you prescribe those horrible medications to patients? And I said, yes. I was trying to eat my turkey. It was Thanksgiving. So I was like, yes, I do prescribe those medications because studies have shown that they reduce the incidence of hip fractures in 3 years in people with osteoporosis. So they reduce the incidence of fractures. And I say, most of the people that talk about this, nobody really knows this thing that goes boom in the night called avascular necrosis of the jaw. But almost everybody knows someone who's had a hip fracture who ended up in the hospital. Yeah. And she's like, oh yeah, my neighbor. I was like, yes, that's what I'm talking about. Yeah. Right? Yeah. So everybody knows somebody who's had a hip fracture, but very few people know anybody who's had this avascular necrosis of the jaw. And so I'm not just saying, oh, it does. Of course, it exists, but the incidence is like 1 per million.
Mm-hmm.
And so there are things that we can do to minimize the incidence of this happening. One, good dental hygiene, right? Mm-hmm. So we make sure that we minimize the likelihood that you have to get teeth pulled in the first place. Two, we want to be careful. We monitor the bone density test every year. And so we're not looking for perfection. We're just looking to get your bone density to a point where the risk of breaking a bone is significantly low. And so once you check your bone density and you get to that point, we give you a holiday from the medication, mm-hmm. right? So that the bone cells can regenerate, and then we can, address it. And, we check the bone density every year. If things start to backslide, then we can consider, restarting medications. And we have different medication options. Sometimes it's a matter of kind of going from one medication group to another one, just to make sure we minimize side effects and optimize the efficacy.
So we should probably come to a little bit of a close here. I feel like we could talk all day, and I hope that we get to do this again at some point.
I hope so. Thank you so much, Jillian, for having me. I really enjoyed our time here. And I look forward to listening to your podcast.
Yeah, there's this great one.
Right now, I'm in car university. So when I'm in the car, that's what I'm listening to podcasts. Yeah.
Well, we just did this great show with this rheumatologist named Dr. Dada. You should totally listen to this show. She was fabulous.
Thank you, Jillian.
This has been such a treat, and it's so fun. We talk a lot about integrative medicine, but part of the integration is that no one system has all the answers. And so everything that we talked about today about the modern perspective of rheumatological disease, about the immune system, I think can help all of us think about our lives. How do we take our trash out? What are we doing for ourselves to keep everything so clear and even? What are we doing for ongoing self-care and restoration, rejuvenation? How do we keep our immune system mellow? So
Exactly.
Thank you so much. So Dr. Dada can be found at the Overlake Arthritis and Osteoporosis Center in Bellevue, Washington. Thank you all for listening today. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can get more information about Dr. Dada at her website, which is
arthritis and osteoporosis.com.
Excellent. Or about us at centerforhealingneurology.com. Or even better, come see either of us in our clinics here locally in this larger Seattle area, Bellevue and Seattle. Be sure to share this show with your friends. We welcome your rating and review wherever you get your podcasts, and feel free to send your topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and see you next time.
Partyfish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.